So let's talk about the lymphatic system now. This topic has assumed importance in the last few years, where a few questions have been asked regarding some clinical signs seen in lymphedema and also about the conditions which give rise to lymphedema. Also, cystic hygroma is an important topic which I'll be covering in this module. So before I talk about the conditions, what is the function of the lymphatic system? Well, the function of the lymphatic system is to return protein-rich fluid back into the circulation. So that's the function of the lymphatic system. And if we talk about the embryology and the development of the lymphatic system, it starts as 6 to 7 weeks of gestation, and it starts as 4 cystic spaces, one on each side of the neck and the groin, right? So you have the jugular and the inguinal lymphatic sacs which are there. The lower limb and the abdominal lymphatics drain via the cisterna chyli into the thoracic duct. And the thoracic duct opens in the left IJV at its confluence with its subclavian vein. And why is this important? This is clinically very important because this is the reason that can give rise to a left supraclavicular lymph node. This can give rise to left supraclavicular lymph nodes, which can be seen in any abdominal or GU malignancy, and it is a sign of advanced disease. So how does this left supraclavicular lymph node get involved? It is because of the involvement of the thoracic duct, and the thoracic duct is opening at the confluence of the IJV and the subclavian, and that's how this lymph node gets enlarged in these cancers. So this is very important, and this is also known as Troisier's sign. This is known as Troisier's sign or Virchow's node or left supraclavicular lymph node. This is how that lymph node is involved. So this is an important surgical correlate which you should know. The head and neck and the arm lymphatics drain into the right IJV. Right? Now, one more thing which you should know, that if some of the lymphatic tissue gets sequestered, that can give rise to a cystic hygroma, which I'll talk about in some time. To discuss the anatomy of the lymphatic system, the initial lymphatics are endothelized capillaries. So they're like capillaries, and these drain into the terminal lymphatics, which have bicuspid valves, right? So these terminal lymphatics have bicuspid valves, and these valves partition them into structures what are known as lymphangions. And these lymphangions are contractile structures. They are contractile in nature, which help in pushing lymph forward. They help in pushing lymph forward. And you should also know that they also act in the same mechanisms as the Starling's law in heart. They act in the same principle as the Starling's law in heart. And what was the Starling's law in heart? That the more the heart muscle stretches, the more forcefully it is going to contract. Similarly, if there's more stretching or if these lymphangions fill up more, the more will be the contractility and more they will push the lymphatic fluid forward. Okay, so they are contractile and they help in pushing the lymph forward. The terminal lymphatics drain into lymphatic trunks, which I've already told you about. Now, how does lymph move forward? Because a lot of lymph coming from the lower limb has to come anti-gravity. So how does it move up? So there is transient increase in the interstitial pressure secondary to muscular contraction. So because of muscular contraction, it pushes the lymphatic fluid upwards. There's sequential contraction of the lymphangions, which I've told you, and reflux is prevented by the valves. So this is how lymphatic fluid moves forward. So this was regarding the embryology, anatomy, and how lymph fluid moves forward. Let's talk about the first condition, and that is cystic hygroma. Cystic hygroma, I told you, is nothing but sequestered lymphatic tissue. This is sequestered lymphatic tissue, and I told you that there are two neck lymphatic sacs, cervical lymphatic sacs, and inguinal lymphatic sacs. Okay, so if some tissue gets sequestered, that forms into a cystic hygroma. Now, cystic hygroma, the most common site is the posterior triangle of the neck. The most common site is the posterior triangle of the neck, but it can also be seen Other sites, what are the other sites where it can be seen? It can be seen in the axilla. It can be seen in the axilla, or it can be seen in the inguinal region as well. But the most common site is the posterior triangle of the neck. This you should know about, as you can see in the image as well. Now, cystic hygroma, let's first talk about the clinical features, and then I will tell you the various presentations which have also been asked in the exam. So the clinical features, this is a fluid-filled swelling. So it is a cystic swelling. It is a cystic swelling. So we know because it is a cystic swelling, what sign will it show? It will show fluctuation. We've discussed this, that any cystic swelling will show fluctuation. It is partly compressible, and I've already told you in the hernia module, I've told you the difference between compressibility and reducibility. Compressibility is usually seen with vascular swellings, and that is when you press the swelling, it will go down, but as soon as you release the pressure, spontaneously it comes back up. That is compressibility. That without a counter pressure, it will again fill up. Whereas a hernia which is reducible, there has to be a counter pressure. Patient has to cuff or strain, and then only it will come out again. So it is partly compressible, and because there is clear fluid present, that is why it is brilliantly transilluminant. It is brilliantly transilluminant. And I have also mentioned to you what are the other transilluminant swellings. Correct. You have ranula, you have hydrocele, you have epididymal cysts, and cystic hygroma. These are all brilliantly transilluminant swellings. Okay. So these are the clinical features with which, when we examine the patient, these are the clinical features which we can see in the patient. Now, what are the various presentations which can be seen in a cystic hygroma? And all these presentations are extremely important. So this cystic hygroma can be detected in an in utero ultrasound. It can be detected on an in utero ultrasound. And you must have been taught in gynecology by Dr. Sakshi that this is a soft indicator of chromosomal abnormalities. It is a soft indicator of chromosomal abnormalities in a child and can also hint towards Down syndrome. The second presentation is it can increase in size and it can lead to obstructed labor. It can become so big that it can give rise to obstructed labor. What else can happen? It can give rise to respiratory distress. It can press on the respiratory passage and it can give rise to respiratory distress. Right? It can present as a swelling in a child like I showed you in the image, and it can also get infected. And there can be secondary infection in a cystic hygroma as well. So these are the various presentations which you should know about in a patient with a cystic hygroma. How do we confirm the diagnosis? The diagnosis will be confirmed by an FNAC. On FNAC, we will aspirate clear fluid and the cytology will show us that it is lymphatic in nature. And the management of these patients is aspiration. You aspirate it, followed by surgery. Surgery is the mainstay of treatment. You have to carry out excision for this patient. In very large lesions, we can do aspiration plus sclerotherapy. Sclerotherapy can help in reducing the size of the lesion, and this can be followed by surgery, right? So you first aspirate and do sclerotherapy, and that can reduce the size of the lesion, and then you can carry out surgery. Ultimately, you have to carry out surgery as that provides the long-term benefit in these patients. One very important question, I told you the theme these days in surgery exams is to ask about nerve injuries. So which nerve can get injured if you have a cystic hygroma in the posterior triangle of the neck? Cystic hygroma in posterior triangle of the neck, which is the most common site. Which nerve can get injured while surgery? So this is a very important question. Correct. We've discussed this. It is the spinal accessory nerve. The spinal accessory nerve can get injured because it travels superficially in the posterior triangle of the neck, and that can get injured and that can give rise to shoulder dysfunction. Right? Remember we discussed about the movie Pushpa, where that guy is always, when he walks, it's bent towards one side. So that's because of the spinal accessory nerve injury. So that's what will happen. You can get shoulder dysfunction if you're operating in the posterior triangle of the neck and you injure this spinal accessory nerve. So this was regarding cystic hygroma. This is often asked as a short note in your college exams as well. Now, acute lymphangitis is acute infection of the lymphatic ducts. Infection of the lymphatics is called acute lymphangitis. The organisms involved have been covered by Dr. Shivika. So you can either have streptococcal infection or it can be Staph aureus that can give rise to this. And the clinical features are that the patient is going to come with extreme pain. There will be a reddish streak. A reddish streak will be seen. So you can see this reddish streak. There'll be extreme pain, reddish streak. There can be fever as well in these patients. And in my career of as a breast surgeon of almost 12 years now, I've only seen acute lymphangitis in 2 patients of mine who had lymphedema and developed lymphangitis. And it was extremely, extremely painful. A reddish streak running right from the dorsum of the hand till their axilla. And one of the patients even required IV antibiotics and admission into the hospital to treat the problem. So the management of these patients is we have to do limb elevation. Limb elevation has to be done. Analgesics have to be given because it's an extremely painful condition, right? And we have to give these patients antibiotics. Broad spectrum antibiotics are to be given. IV antibiotics might also be required, like I just told you. Now, in patients where pain is persisting beyond 48 hours, or there is fever also which is occurring beyond 48 hours, we should suspect an abscess. And in these patients, we need to carry out incision and drainage as well. And you should know it is very important for us to treat acute lymphangitis properly, because if acute lymphangitis is not treated properly, then it can give rise to lymphedema as well in the long-term setting. So adequate antibiotics and treatment have to be done so that it does not develop into lymphedema later on. Now the main topic of this module is lymphedema. Lymphedema is nothing but excessive interstitial fluid. ISF is excessive interstitial fluid is lymphedema. And lymphedema, I've told you the definition is excessive interstitial fluid. And basically the pathophysiology is that it occurs due to inability of the lymphatic system to clear the interstitial fluid compartment. So when the body cannot clear it out, that is when lymphedema will develop. Now there are 2 types of lymphedema. You have primary lymphedema and secondary lymphedema. So in primary lymphedema, what happens that production is normal, but there is defective lymphatics. There are defective lymphatics. So either the valves are injured or the lymphatic ducts are not properly developed. So that is what leads to primary lymphedema. And we'll talk about the 3 types of primary lymphedema in some time. Secondary lymphedema occurs when there is increased production or defective drainage. So it can occur because of increased production. Increased production can occur in inflammatory conditions, excessive production can occur. Defective drainage can occur in something like filariasis, where there is destruction of the lymphatics, and that can give rise to defective drainage as well. So these are the 2 broad types of lymphedema which are there. We are going to discuss both of them in detail. Now there is lymphatic hypertension and lymphostasis, which can give rise to increased interstitial fluid. And when there is increased interstitial fluid, one very important thing is that inflammatory factors are released. And because of the release of these inflammatory cytokines and interleukins, in the long run there can be fibrosis and skin changes. So initially skin changes and fibrosis won't be there, But if lymphedema is not treated properly, then it can give rise to skin changes in the long run as well. The clinical features of lymphedema. So the patients with lymphedema are mainly going to come with limb swelling. This is the most common presentation of patients with lymphedema. Pain is a major concern for them. There can be dull aching pain, or it can be sharp pain if there is acute lymphangitis. And in the long run, there can be skin changes as well, which we will discuss. So there is a clinical classification of lymphedema. When you see the patient, you always try to classify the patient into one of these types, and this is known as the Brunner's classification of lymphedema, which is very, very important for the exam. This is mentioned in both Bailey and Sebastian. This is the Brunner's classification of lymphedema, which you need to remember, where subclinical or latent lymphedema is when there's excessive interstitial fluid and histological abnormalities in the lymphatics, but no clinically apparent lymphedema. There is no clinically apparent lymphedema. Right? Grade 1 is pitting edema. Grade 1 is pitting edema, which disappears on elevation and bed rest. Grade 2 is non-pitting edema. And grade 3 is when irreversible skin changes occur. That is grade 3 lymphedema. Right? So these are the Brunner's grades which you should remember for the exam. This has been asked multiple times. So you can see in this image, you can see that this is a stage 1 lymphedema, right? Stage 1 where you can have pitting, stage 1, stage 2, stage 3, it becomes non-pitting, and stage 4 is when you can see that chronic skin changes have developed in this patient. There are certain signs also which you should know, certain skin changing signs which you should know about. They have also been asked in the exam. So you can see here that there is loss of the ankle contour. There is loss of ankle contour. The hollow of the ankle is lost, and this is known as a buffalo hump. And the dorsum of the foot, the skin becomes, and the dorsum of the foot, the skin becomes fibrosed. The skin becomes fibrosed and it cannot be pinched. And this is known as Stemmer's sign. Stemmer's sign is when you can't pinch the skin over the dorsum of the foot. This is known as Stemmer's sign. So when the skin over the dorsum of the foot cannot be pinched, this is known as Stemmer's sign. Also, there is squaring of the toes. And why the squaring of the toes occurs? Squaring of toes occurs because of two reasons. One is because of fluid accumulation, and second is because the leg size increases and the space in the shoe is limited. So that leads to squaring of the toes. So that can also happen. And these patients are prone to fungal infections. So they can present with fungal infections and cancers as well in the long run, which I will talk about in the complications. I'll cover later the complications of lymphedema. I'll talk about them later in detail. And you should know that lymphedema is a clinical diagnosis. It is a clinical diagnosis. So you have to examine the patient to confirm that whether the patient has lymphedema or not. Now, once you have confirmed that the patient has lymphedema, we have to carry out certain investigations. Now, investigations, one would be to see how much lymphedema is there, to quantify it. And number two, to find out what is the cause of the lymphedema or what type of lymphedema is there. Okay. So to quantify the amount of lymphedema, we carry out limb volume measurement, right? This is to quantify the lymphedema. And the gold standard for quantification, of lymphedema is called water plethysmography. So in water plethysmography, we basically see how much water is getting displaced, and that tells us what is the quantity of lymphedema in that limb. Mild is when it is less than 20%, moderate is 20 to 40, and severe is more than 40%. Now, a crude method is what we do in colleges or what we teach medical students, because we can't do water plethysmography in the ward. So what we do is we do simple measurement. And I have just made a short clip of how we do the measurement in our patients with lymphedema after breast cancer surgery. So I'll just show you that clip, and you can follow this. If you have to document lymphedema in your clinical wards, you can follow this. But keep in mind that it's a very crude method. It is not the best method. So you see that we choose one constant point from any bony landmark, and it should be the same on both the sides. So here I have chosen that point, and then I do the limb volume measurement using a measuring tape. So you can see on this side, the limb volume measurement is coming out to be approximately 9.5 is what it is coming out on this side. Similarly, or 9 is what it is coming out. And then we measure at the same distance on the other side as well to see what is the limb volume measurement and see if there is a marked difference between the two. That will tell us if there's lymphedema present or not. But the best method is water plethysmography. Now, the gold standard test to figure out the type of lymphedema, gold standard for type of lymphedema is direct lymphangiography. So direct lymphangiography is an invasive test where we are going to inject a dye, where a dye is injected into the lymphatics in the web space. So in the web space, we directly inject this dye into the lymphatics. And if you remember the breast module, I told you about this new dye which we are using, that is called ICG. This is indigocyanine green dye which can be injected, and this is going to highlight the lymphatic tract and it will tell us what are the abnormalities in the lymphatics. So if we talk about primary lymphedema, there are 3 types of abnormalities which you can get in primary lymphedema. So when we do direct lymphangiography, we can get 3 types of appearances in primary lymphedema, right? So the first type of appearance is congenital hyperplasia of the lymphatics. Congenital hyperplasia of the lymphatics is seen in 10% patients, and in this there is increase in the lymphatics, but these lymphatics are defective. And males are more commonly affected in this than females, and unilateral equal to bilateral, right? Unilateral equal to bilateral, and there is variable response. There is variable response to therapy in these patients. Distal obstruction is the most common appearance which you get. Distal obstruction is the most common appearance in primary lymphedema. This is seen in almost 80% patients. And there is absent or reduced distal superficial lymphatics associated with aplasia or hypoplasia. It is often bilateral, and these are the patients who get maximum benefit from therapy. And this is the most common. So when I talk about primary lymphedema, the most common primary lymphedema is lymphedema precox. Right? Precox is which occurs around the pubertal age, so after 2 years of age till 35, but the maximum peak incidence is around puberty. So in precox, majority of the patients have distal obstruction type of feature on direct lymphangiography. Proximal obstruction has the worst prognosis. It is rapidly progressive, and this is also seen in 10% patients. And here there is obstruction at the level of the aortoiliac and the inguinal nodes. So that is where the obstruction is. That is called proximal obliteration. So these are the 3 appearances which you can get when you do direct lymphangiography in patients with primary lymphedema. Another very useful investigation is a single slice of CT at the level of the calf. And in Bailey and Sebastian both, this has been written. This is very important. This is a single axial CT through the mid calf is a useful test which helps in differentiating lymphedema from venous edema from lipedema. So there are 3 conditions which it can differentiate, and you should know the findings because they've been mentioned in both the books. Lymphedema, you will get a coarse, non-enhancing, reticular honeycomb type of pattern. right? So honeycomb type of pattern in the enlarged subcutaneous compartment is what you're going to get in lymphedema. Venous edema, you will get increased volume in the muscular compartment. And lipedema, you will just get increased subcutaneous fat, but you will not get the reticular honeycomb kind of pattern. Clinically speaking, lipedema is usually symmetrical. It is usually symmetrical. It is usually bilateral, whereas lymphedema can be unilateral as well. It is more common in females as compared to males. So these are also some clinical features which can help in differentiating lipedema from lymphedema. So these are the various investigations which are done in a patient with lymphedema. Now let's talk about the individual conditions, that means primary lymphedema and secondary lymphedema and their management. So primary lymphedema, as I told you, primary lymphedema is when there are defective lymphatics. And I've already told you about the 3 appearances which we can see in direct lymphangiography. Now, lymphedema congenita is the first type of primary lymphedema, which is seen between 0 to 2 years of age. Males are more commonly affected than females, and it can involve multiple limbs. It can involve the face and the genitalia as well. Now, primary lymphedema can either be familial or it can be sporadic. The familial form is known as Noon-Milroy syndrome or Noon-Milroy disease, which is due to the mutation of the FLT4 gene and the VEGF4 gene. So the FLT and the VEGF genes are implicated in Noon-Milroy syndrome, which is seen in lymphedema congenita. Lymphedema precox, the question which has been asked, this is the most common type of primary lymphedema. Most common type of primary lymphedema is there. This is lymphedema precox between 2 to 35 years of age. But I told you the peak incidence is around puberty. Females are more commonly affected than males. And it is usually unilateral till the knee. Usually unilateral till the knee. And again, this can be sporadic or familial. And the familial syndrome is known as Meigs disease, which is because of the GJC gene. The last one is lymphedema tarda, which is rare, which occurs after 35 years of age. So these are the 3 types of primary lymphedema. In this, predominantly, you should know that lymphedema precox is the most common, and you should know about Noon-Milroy and lymphedema congenita and Meigs syndrome in lymphedema precox. Also in Bailey, there are 3 more syndromes which I want you to know. Although they've not been asked in the exam, I'm just trying to be more thorough because with the next exam coming in, there can be multiple questions which can be asked from these topics. So let's just know about these syndromes in the back of the mind. So because of the FAT4 gene, there can be microcephaly, unusual face and lymphedema affecting all 4 limbs, and this is known as Hennekam syndrome. And there's abnormal lymph drainage in all 4 limbs and the thoracic duct. Because of GATA2 gene, there can be myelodysplasia. This is known as Emberger syndrome, warts, recurrent viral or bacterial infections, and predisposition to several cancers. There is hypoplasia of the lymphatics in these patients. And because of the IK-BKG gene, you can get ectodermal dysplasia, anhydrotic osteoporosis, and immunodeficiency. And this is known as Ollendorff syndrome. So again, not been asked in various exams, but just these 3 syndromes, please just remember the names that they are or they can be associated with lymphedema. If you're preparing for the super specialty exam or the INI CET exam, it would be good if you can remember the genes as well. Now, secondary lymphedema is more common than primary, and I've already told you the pathophysiology. The pathophysiology is either increased production of the interstitial fluid or defective drainage of interstitial fluid, which can give rise to secondary lymphedema. Now, secondary lymphedema, the most common cause of lymphedema overall and in the lower limb is filariasis. This question has been asked in the exam. And the most common cause of lymphedema in the upper limb is post-mastectomy lymphedema. After breast cancer surgery, when we remove the lymph nodes, we've already discussed this, that there can be lymphedema. So these two one-liners you should know for the exam. Overall, it is filariasis, and lower limb it is filariasis, and upper limb it is post-mastectomy lymphedema. So post-mastectomy lymphedema, this is something which I see routinely in my clinical practice, because if you remember in the breast surgery module, I told you the risk of developing lymphedema is 2 to 10% after lymphatic clearance. After lymph node clearance, this is the risk of developing lymphedema after breast surgery. The incidence is reduced. Incidence is reduced because of which technique? Correct. Because of sentinel lymph node biopsy. The incidence has gone down, but increased incidence is seen. Increased incidence is seen if radiotherapy is also given to axilla. Radiotherapy also given to axilla after surgery. So if you have cleared the axillary lymph nodes and then you give radiotherapy to the axilla also, that will increase the risk of lymphedema in patients. And also if we clear the lymph nodes above the axillary vein. So that is why, if you remember, the superior boundary of lymphatic clearance is the axillary vein. But if we go above the axillary vein, that can also increase the risk of lymphedema. I told you that seroma is fluid accumulation that has no link with lymphedema. So this is post-mastectomy lymphedema, and it is the most common cause of upper limb lymphedema. This I have also covered in the breast module when I spoke about the complications of breast surgery. Elephantiasis or filariasis. Elephantiasis can develop secondary to filariasis. It can develop secondary to filariasis, and this is because of Wucheria bancrofti, which can be transferred as a bite from a mosquito. Through that bite from the mosquito, this problem can occur, and this organism, Wucheria bancrofti, can go and cause destruction of the lymphatics. It can cause destruction of lymphatics, both distal and proximal, initially distal and proximal, and it can give rise to lymphedema. It can give rise to lymphedema. The management of elephantiasis, you know, the diagnosis can be made that this microfilaria can be identified in blood, and it usually comes in blood in the night time. So you take a nighttime peripheral smear, and that is when you can detect the microfilaria. The management of these patients, so DEC is the drug, you have studied about it in pharmacology. This is given, this kills the microfilaria, it kills the microfilaria, but it cannot reverse the lymphedema. It can kill the microfilaria, but it cannot reverse the lymphedema or the skin changes which have already developed. So for that, the management is different. And why is it called elephantiasis? Because the appearance is like an elephant's leg. The legs can really swell up, and the appearance is almost like the leg of an elephant. And I wanted you to see this image as well. This image I clicked in Kabini. So I'm very fond of wildlife photography, and when I was doing my first fellowship in Bangalore, so I visited almost all the wildlife sanctuaries in South India, and this was a picture which I clicked in Kabini. So you can see that the legs are uniformly thick and huge, and that is the appearance which you get in patients with elephantiasis or filariasis as well. This was another very interesting case which I wanted to share with you, and this is a case report which I have published in an index journal on PubMed. This was vulvar elephantiasis or vulvar filariasis, which you can see the vulva had become huge in size. And I remember because I was an undergraduate student. I was a 4th year undergraduate student when I had assisted in this surgery, and my only job was to hold this 10 kg mass and stand as the surgeon was resecting it. But it was such a big lesion. It was one of the cases which I can never forget, and that's why eventually we published it as well. So I've told you about primary and secondary lymphedema. Now moving on to the complications of lymphedema. I've already told you infection can occur and this can give rise to lymphangitis, which I've already covered in the starting of this module. The skin changes and the skin signs, I've already told you about Stemmer's sign, about buffalo hump, about squaring of toes, and these patients are also more likely to develop cancers. Also, I've told you that they can also develop fungal infections, right? So cancers is another thing which these patients can develop, and one of the major ones which you need to remember for the exam, which has been asked lots of times, is called Stewart-Trevis syndrome. Now you would remember that Stewart-Trevis syndrome I've also covered when I spoke about the breast surgery module as a complication of post-mastectomy lymphedema. Just to recapitulate, Stewart-Trevis syndrome is the development of angiosarcoma in long-standing lymphedema. And what do we mean by long-standing? By long-standing, we mean that it is usually 8 to 10 years of lymphedema. After that only this condition develops. And how does it present? It presents as bluish, reddish nodules. It presents as bluish or reddish nodules over the skin. So you can see in the image long-term lymphedema, and these bluish or reddish nodules develop over the skin, and when you biopsy them you will find angiosarcoma. The management of these patients is aggressive surgery, and you also need to give them chemotherapy, but usually this condition has a bad prognosis. Right? So please remember that it is a lag of 8 to 10 years is usually there, not few months, it is 8 to 10 years. That is what you need to see in the question stem when the exam comes, when it comes in the exam. And it is the development of angiosarcoma. Okay. There are other cancers also which can develop in long-standing lymphedema. The other cancers are Kaposi sarcoma, squamous cell sarcoma, liposarcoma, basal cell cancer, malignant melanoma, and lymphomas. But for your exams, what is important is Stewart-Trevis syndrome. One more complication, which can be a skin complication, is when these lymphatics which have been there for long term, they're dilated, they can get thrombosed and fibrosed, and that can form a lymphangioma, right? That can form a lymphangioma. One of the types of lymphangioma was a cystic hygroma, which was a cavernous lymphangioma, right? But if you have long-standing lymphedema, then these nodules can form, and these are also called lymphangiomas. And Bailey and Sebastian both write that lymphangioma circumscriptum is when these nodules are less than 5 centimeters in size. Lymphangioma diffusum is when they are more than 5 centimeters in size. And lymphangioma ab igne is when they are arranged in a reticular fashion. So these are the various complications which can be associated with lymphedema, whether it is primary or secondary. Now moving on to the management of lymphedema. So management of lymphedema is a teamwork. It cannot be done by just one person. The surgeon is also involved. The physiotherapist is also involved. There are special lymphedema management nurses also which are there. So first is pain relief. I told you majority of them suffer from some kind of pain, whether it is sharp shooting pain or dull pain. So you have to give adequate pain relief to ensure good quality of life. Skin care is of paramount importance because if skin is not properly taken care of, there can be repeated infections, and finally there can be cancers in the long run as well. So these are all points taken from Bailey and Sebastian, and you should know about these points regarding skin care. So this is what I tell all my patients after breast cancer surgery as well. In fact, I've made a special YouTube video where I share that with them so that they can be reminded again and again about the skin care regarding after surgery, so that they don't develop lymphedema, and if they've developed lymphedema, what precautions they need to know. So they need to protect their hands while washing or gardening, and if they do get a cut, then we do give them an antibiotic ointment to apply on them. Then never walk barefoot, always wear protective footwear when they're walking outside. Use an electric razor to depilate, right? Don't use a blade. There can be cuts which can be there. Never let the skin become macerated. So it should not be left dry. It should not be left wet. If it is left wet, it can predispose to infections. Cuts and grazes should be treated promptly, like I just told you. Very important, whenever our patients are traveling to a place where there are a lot of mosquitoes, we tell them to use mosquito repellents. So because of that mosquito bite also, that can trigger lymphangitis. And if the limb becomes painful or swollen, they should immediately come to us. And very important advice which we give to our patients post surgery, that they lifelong they cannot use that arm to give blood samples or to get injections. In fact, we go a step further and we tell them no BP measurement also from that arm. So it should be protected from the sun, and antibiotics they should carry if they are going on a holiday. Please remember that antibiotics should only be used if you're suspecting an infection. There is no role of just putting these patients on long-term antibiotic therapy. Now, the most important part of lymphedema management is to control the swelling, because that is the most bothersome thing for the patient. So control of the swelling, we carry out decongestive lymphedema therapy, DLT, decongestive lymphedema therapy. And this decongestive lymphedema therapy is divided into two phases. The first phase is under the supervision of a lymphedema expert, right? So first phase is an intensive phase, which is under the supervision of an expert, and this includes manual lymphatic drainage and multi-layer lymphedema bandaging. These are included in the first phase of decongestive lymphedema therapy. Once the acute swelling has been taken care of, then you come with the maintenance phase, which lasts almost lifelong, and this is a self-care regime which the patient has to follow on their own. Now, to reduce the swelling, there can be multi-layer lymphedema bandaging, and this multi-layer lymphedema bandaging, the advantages is that it reduces the edema, it restores the shape of the affected area, it reduces skin changes, and that is why it is very important that this is initiated early before permanent skin changes develop. So that is very important. You have to tell the patient that as soon as you start lymphedema management, it is better, because once permanent skin changes develop, then they can never be reversed. It eliminates lymphoria, it supports inelastic skin, and it softens the subcutaneous tissue. So these are the advantages of the multi-layer lymphedema bandaging. Now, we also spoke about lymphedema bandaging and about compression garments in the venous system, right, or in patients with varicose veins. So what are the differences between the bandaging or the pressure garments for lymphedema versus the pressure garments for varicose veins? So these pressure garments or these lymphedema bandages, there should be 100% pressure at the ankle. There should be 100% pressure at the ankle. Right. There should be 70% at the knee. It should be 50% in the thigh and 40% pressure in the groin. Right. Now, the pressure required is more than. So the pressure for these garments and these bandages is more than what is required for varicose veins. Right? So for the upper limb, it is 30 to 40 millimeters of mercury. If you remember in the varicose veins modules, for lower limb it was 30 to 40 millimeters of mercury. Here for upper limb it is 30 to 40, and for lower limb it is 40 to 60 millimeters of mercury is the pressure which we require. So this is a very important point which is written in both Subiston and Bailey, which you should know about for your exam. Also, one more thing which you should know, that there can be coexistent There can be coexistent arterial disease. There can be coexistent arterial disease as well. Therefore, the ankle brachial pressure index should be more than 0.8 or 0.9 to carry out this therapy. Right? You know what ABPI is. I've covered ABPI in the arterial module. It is very important. It is ankle brachial pressure index, and the ABPI should be more than 0.8 to 0.9, and then only you can do this compression stockings or multi-layer bandaging. This was the same case for varicose veins as well, because if you put lots of pressure in a limb which is not getting proper blood flow, you can precipitate ischemia in that limb. So if anyone has arterial disease, you need to be careful about doing these therapies in these patients. Another thing which can be done is pneumatic compression stockings. And pneumatic compression stockings, you can see the image here. So like we've discussed, the pneumatic compression stockings which act as preventive measures for deep venous thrombosis. Similarly, you have lymphopress machines which can press the lymphedema fluid out and can send it to circulation. So we use it for our breast cancer patients as well, and I'll just show you a short clip regarding what it looks like and what exactly is done. So you can see the lymphopress machine. We cover the entire arm, and it is connected with a motor which keeps on pressing it sequentially so that it reduces the lymphedema. Again, it is more useful if these pneumatic compressions are done before permanent skin changes have developed. Okay, so this was the medical management in a patient with lymphedema. So this was regarding the pneumatic compression stockings. One more advice which we give to the patient is regarding exercise, and again this is written in both Bailey and Sebastian, that vigorous anaerobic isometric exercises can worsen the lymphedema. So lifting weights, lifting heavy shopping bags, all these can worsen lymphedema, and we tell our patients not to do that. But slow rhythmic isotonic movements are useful. Right, slow rhythmic isotonic movements are useful. This has already been asked in the super specialty exam. So exercises like swimming are very helpful. They help in reducing lymphedema. So this was regarding the medical management in a patient with lymphedema. Surgery can also be done. And what are the indications for surgery? So surgery will be carried out if there's increase in swelling despite medical management, right? Or if the patient is developing skin changes, or recurrent infections. That is when we contemplate surgery in these patients. Now, surgery can either be reconstructive surgery. Surgery can either be reconstructive surgery, or it can be resective surgery, or it can be resection of the excess volume which has developed. So if we talk about the reconstructive surgical options, they are gaining a lot of popularity, the reconstructive surgical options. So the reconstructive surgical options are, you can do Kinmouth procedure. Kinmouth procedure is when you do an ileal mucosal patch, anastomosis, and with this ileal mucosal patch, the lymphedema fluid is sucked out. Nebulowitz is the one which is being done very commonly these days. Nebulowitz requires super microsurgery. It requires super microsurgery because these lymphatics are very narrow, and this is anastomosis of nodes and lymphatics with veins. So in fact, in a lot of centers across the globe, what they are doing, that if you're suspecting a breast cancer patient will develop lymphedema, then during the surgery itself, during axillary clearance itself, they are anastomosing the nodes and the lymphatics with the veins. And these veins and lymphatics can be identified using ICG technique, which I showed you in the breast module as well. So this is Nebulowitz surgery, which is also being done routinely. So these were the reconstructive surgical options. In the MCQ exam, the resective options have been asked in the exam. So this is Hohmann's procedure. This is Hohmann surgery. Homan surgery is when we remove wedge of skin and subcutaneous tissue. When wedge of skin and subcutaneous tissue is removed, you can see in the image that wedge of skin and subcutaneous tissue is removed. The most common complication which can occur here is skin necrosis. Most common complication is skin necrosis, and this is the most satisfying for calf. This is the most satisfying surgery for calf lymphedema. If there's lymphedema at the calf, this is what is written in Bailey, that this is the most satisfying surgery. So another resective procedure is the Thompson procedure. And in the Thompson procedure, as you can see in the image, we raise a flap. So you can see a flap is raised, and once we've raised the flap, we clear out all the subcutaneous tissue from the flap, and we de-epithelize the flap. We de-epithelize the flap and we suture it. So we raise the flap. We raise the flap, right? Then we clear out all the subcutaneous tissue, and then we bury the flap. We bury the dermal flap, right? This is Thompson's procedure. This can also reduce the limb girth. And again, the most common complication here also is skin necrosis. Most common complication in Thompson's also is skin necrosis. Okay. Sistrunks procedure, Sistrunk surgery. Remember, Sistrunks we'd also studied in thyroglossal cysts. So Sistrunk surgery can be done for lymphedema as well, where a wedge of skin and subcutaneous tissue is resected. Wedge of skin and subcutaneous tissue is resected, and primary closure is done. Sistrunks is in fact the most commonly done resective surgery procedure. So it is the most commonly done resective surgery procedure, that is Sistrunks procedure. Charles procedure is the most disfigurative procedure. It gives the worst outcome. It gives the worst cosmetic outcome. And in Charles procedure, what is done is that the entire tissue is removed, and then split thickness skin grafting is done. STSG, we've discussed this in the plastic surgery module. Split thickness skin grafting is done over it. This gives the worst cosmetic outcome of all the surgeries. You can see in the image as well. So you can see in the image that it gives a very bad cosmetic outcome following the procedure. So this is the worst cosmetic outcome. So these are the various surgeries which can be done in patients with lymphedema. So in this module, I've told you about lymphedema, which is of course the main topic, but you should also know about cystic hygroma. Also the investigations of lymphedema you should remember for the exam. Now for the final year students, like we've been doing in all modules, let's make a list of the short notes. So you can get a short note on lymphedema management, on Stewart-Trevi syndrome, and you can also get a short note on cystic hygroma. So these are the short notes which you should prepare from this topic. Before we end, let's quickly do some MCQs. Lymphangioma forming a reticular pattern of ridges. I told you this is known as lymphangioma ab igne. And circumscriptum is less than 5 centimeters and diffusum is more than 5 centimeters. Regarding surgeries for lymphedema, which of the following statements is not true? Charles procedure is associated with a poor cosmetic outcome. Graft failure is common. This is true. Pilonidal sinus formation can be seen following Thompson's procedure. Homan's procedure involves excision of all tissue followed by split thickness skin grafting. This is false. Pilonidal sinus can form following Thompson procedure, and skin necrosis is the most common complication of Homan's procedure. So you should also know pilonidal sinus can form following Thompson. Which of the following is not advised as supportive measure in the management of lymphedema? So this we've already discussed, that isometric exercises should not be done, as they can worsen the lymphedema. Slow rhythmic isotonic exercises like swimming can be done. This was asked in the UPSC CMS exam. Which of the following statements regarding lymphedema are correct? Patients experience constant dull ache and even severe pain sometimes. This is true. Manual lymphatic drainage has a role. This is true. Primary lymphedema is caused by congenital lymphatic dysplasia. This is true. And Noon-Milroy is a type of primary lymphedema. This is also true. So all the statements are correct here. This was asked in the UPSC. In lymphedema, skin at the base of the toes cannot be pinched due to subcutaneous fibrosis. This is known as Stemmer's sign. Buffalo hump is loss of ankle contour. Moses and Homan's signs, we've discussed. These are signs in DVT. I've also shown you a video of how to elicit these signs. We avoid doing it in a patient with DVT. Final question in this module. This question we discussed previously as well. Long-standing lymphedema post-mastectomy. The patient presents with these findings, and this we've discussed is Stewart-Trevis syndrome, which is development of angiosarcoma in long-standing lymphedema. So that brings us to the end of this module on lymphedema. Thank you.